I'm Judith Feinberg, and I'm delighted to be here. I have so much to say to you that please forgive me, but in my native New York speech, it'll go pretty quickly. I could talk about this for hours because we're in the midst of a really big problem here. So with that said, I want to talk to you about the impact of the opioid epidemic on West Virginia. How did we get here? And what can we do about it? And I want to start first by laying the groundwork to say addiction is a disease, not a failure of will, not a character flaw. It's a disease, and it's actually, sadly, chronic and frequently relapsing brain disease. And what happens from this brain disease is that people have compulsive drug-seeking use, even though it leads them to behaviors that are deleterious to them, like loss of their children, loss of a job. They're compelled by these brain circuits that get set up. And although the initial decision is usually voluntary, because of these brain changes that occur over time, it just gets in the way of self-control. And this is why, the famous Alcohol Anonymous thing about, you're a drunk for life. This is why even when people go into recovery, the risk of relapse is very real, because these brain circuits, while they improve off drugs, they never entirely go back to normal. So there's always that risk there. And this is a functional MRI of brain with the same stimulus. On the left is a normal brain firing, and you can see that there is diminished firing in the opioid-addicted brain. So there really are functional and physiologic and anatomic changes in the brain as a result of addiction. So just what are opioids? And is a technical term for all kinds of narcotics, whether they're prescription drugs or street drugs, and they can be abused in multiple ways. And the most harmful, of course, is by injection, and that's what I'm going to focus on. So we're not only dealing with an epidemic of opioid injection drug use, but we're dealing with multiple congruent epidemics. The technical term in public health speak is syndemics. These are intertwined epidemics. So we have opioid injection, whether it's prescription or street drugs, starting with heroin and now contaminated by these semi-synthetic opioids, fentanyl and carfentanil, that are far more powerful and far more deadly. We have overdoses and overdose deaths. West Virginia has the highest rate in the country. We have endocarditis, which is a bacterial infection of the lining of the heart and the covering of the heart valves. And the heart valves are what open and close to let the blood in and out. So you can imagine that people with endocarditis have impaired heart function. Hepatitis C, we have the second highest rate after Kentucky. Hepatitis B, we have the highest rate. The risk of HIV is very, very high here in West Virginia, and I'll show you a map about that later. And across the country, there are 220 counties that have been, rural counties that have been identified as high risk of an HIV outbreak, and more than half of them are in central Appalachia. We have mother-to-child transmission of all these viral diseases. We not only have syphilis and other sexually transmitted diseases, but now we have babies born with congenital syphilis, something that I have only, as an infectious disease doctor, read about in textbooks. That's how long ago congenital syphilis, and you can see I'm not young, how long ago the congenital syphilis was a medical problem. We have neonatal abstinence syndrome. This is babies who are born to mothers with the disease of addiction. The babies are born addicted, and they go through a terrible withdrawal syndrome. And sadly, West Virginia has the highest rate of NAS too. And lastly, but certainly not least, this leads to disrupted families and a lot of children in foster care who are removed from their family environment because their parents are suffering from addiction. So why do we have a heroin problem? So these are what I'm going to tell you next. These are my concepts, and there might be other things that I haven't thought of, but let me walk you through them. First of all, we learned next to nothing in medical school about prescribing opioids, and we learned absolutely nothing about the disease of addiction. We only learned about these things as we took care of people, and in the era when I trained, most of addiction was alcohol. And then we took care of people who came into the hospital with alcohol-related problems. So one is you don't get much formal education. Second of all, pain medication's reimbursed. And most of the other things that are equally or more effective for the kinds of complaints that most middle-aged people have, which are musculoskeletal pain, like low back pain, they're probably much better treated by physical therapy, but insurance often doesn't pay for physical therapy. So you wind up giving people drugs because that's what their insurance will pay for. And then there was tremendous lobbying by the pharmaceutical industry in the mid-90s to consider pain as the fifth vital sign. You know, the four vital signs are your blood pressure, your heart rate, your respiratory rate, and your temperature. And so a pain assessment was supposed to be part of that. If you go to the doctor for something completely unrelated to any pain, and the intake nurse says to you, "Where's your pain on a scale of 0 to 10, kind of encourages people to say, "Yeah, I got some pain." I have my patients come in and they say to me, "Doc, my knees hurt." I say, "You too?" It's a function of getting older that you're going to ache somewhere, and aching doesn't mean you should have opioids to fix it. In fact, we consume in the United States 80% of the world's prescription opioids, and we represent something like 6% of the world's population. So we have a culture of drug taking that is not very good. JACO is the organization that certifies hospitals, and so in 1998, JACO and the VA said, "Okay, we're going to do this." And because there was this claim that we were somehow undertreating pain, and there was also this totally false claim that there was no addiction risk to giving people opioids for, like, say, back pain, chronic back pain. Patients don't understand that they can become addicted. And typically, physicians will often write for more pills than somebody needs, right? I had finger surgery a few months ago, and my orthopedic surgeon gave me 30 pain pills. I used 3. I think that's very typical for a lot of minor surgical procedures. And then these pills just sit around, and people don't really realize that they can become addicted, but they can. Moreover, medicine is now driven by having your patients sit in judgment of you. Do they like you or not? Are they going to give you a good score? Press Ganey is the company that provides these scores to many hospital systems. And if you don't give somebody a prescription, after all, the nurse has already asked them, "Do you have any pain?" They say, "Yeah, I have a 4. I have chronic back pain." And then you don't give them a prescription for narcotics, you don't get a good grade from that patient. And in some systems, this is tied, your score from your patients is tied to your reimbursement. And in some systems, it actually means if you get really bad scores on a continual basis, you're out of a job. There is this incredible financial pressure now to see patients as fast as you can. And when you talk to people about chronic pain, usually you're talking to them about multiple modalities. You're talking to them about physical therapy. You're talking to them about changing their body mechanics, not using their low back to lift things, using your knees to lift things. This is not easy to do in a 13-minute visit, but it's real easy to write off a prescription. So just in terms of convenience, that's part of it. Bad research. So there was an oncologist in Boston who, just by observing his own patients, said in a letter to the editor of the New England Journal of Medicine that only 4 people got addicted. It was a letter to the editor, wasn't a study, didn't define what addiction was, didn't define what pain medication was or how long people took it. And as a result of this, both academic people in pain management, but especially the pharmaceutical companies that make pain medicine, really harped on this. Like, this was in the New England Journal of Medicine. This was really important. And if you go through the literature, you'll see that this is misattributed many times as if this were proven in a clinical trial as opposed to an offhand observation by one doctor. Pharmaceutical marketing had a lot to do with this. First of all, they promoted this letter to doctors like crazy. They advertised to the public now directly. You have this, we all are required to do so many hours of continuing medical education every year to maintain our licenses. A lot of this CME stuff was in places like this, nice hotels, fancy dinners, golf outings, in the Caribbean. And after a while, that has an impact. And if you may not know, but Valium was the first million and then the first $1 billion drug. And when people saw this, they thought that we can replicate that. So here is a scary map of the United States. The dark purple are the states that have the most painkiller prescriptions. And what the dark it means, because I don't know if you can see this, for every 100 people, there are somewhere between 95 and 143 narcotic prescriptions per year. That is saying for every 100 people, there is probably at least one narcotic prescription in West Virginia and the neighboring states, which are really the center now of this heroin epidemic. And there's tremendous profits to be made. So there are 3 drug wholesalers that manage prescription opioids. One of them is McKesson, and in 5 years, McKesson shipped 100 million pills to West Virginia. West Virginia doesn't even have 2 million people. What is wrong with that picture? And lastly, there's mom and pop drugstores who also saw this as a way to make a killing. So in Kermit, West Virginia, a small town with less than 400 people, in a 2-year span, they dispensed 2 million pills. 2 million in 2 years. So you sort of wonder, why did people in West Virginia become addicted? Because it was ever present and readily available. There were lots of illicit pain mills. This is an entry picture to Portsmouth, Ohio. Portsmouth, Ohio is on the Ohio River, right across from Kentucky and near West Virginia. It's a town of 25,000 people. It had 11 pill mills, 11. People came from all over. Wads of cash stuffed in their pockets. They left with big bottles of pills. And when they reformulated some of these prescription narcotics to make them harder to inject, people were just crushing them and then dissolving them in water and injecting them. When they made the crushing part harder, instead of going into solution, it became a kind of jelly. Heroin took its place. Drug dealing is the ultimate capitalist enterprise. You find a market, you serve it, you got a business. And I love unique pain clinic, legitimate pain care. I want you to know, here's what legitimate meant. 50% of the pain clinics in Ohio were owned by felons, former felons. Very legitimate. So this is a great book, Dreamland by Sam Quinones, who's an investigative reporter for the LA Times. It really talks about how heroin came to this part of the United States. It's really fascinating. And he called it the pizza delivery model. There was a town in Mexico where they were harvesting this black tar heroin. Local people got sent out as the distribution network. You called in an order. In the early days, you beeped someone. Now you do a cell phone thing. You call in an order. They say, I'll meet you at 5th and Vine. They show up. They take a balloon of heroin out of their mouths. They hand it to you. Done. And unlike homegrown dealers, these individuals who were distributing and selling the heroin were not themselves addicted. So they had no skin in the game except to make money and go home to Mexico and live a more comfortable life. They didn't carry guns. There was no violence. There were no shootouts at the OK Corral. And if they got arrested, they just got replaced by somebody else from that town because they made good money doing this. So this is how cheap heroin can be. This is from the Ohio Substance Abuse Monitoring Network. 1 dose of heroin, $10. At the point where prescription narcotics became harder and harder to get, they were costing $1 to $2 a milligram. So the highest dose of OxyContin is 80 milligrams. That meant a dose would cost you $80 to $160. So 80, 10, 80, 10. Even people who didn't want to necessarily use heroin made that transition on just a financial basis. And you can see the availability was easy and the quality was very high. Well, the last thing I think that's part of this is that there's a lot of joblessness and economic problems, especially in the southern part of the state. Right, so this is data actually from WVU. In McDowell County, only 8 out of 25 eligible people participate in the labor force. So here is the US participation rate. Here's the McDowell County. And 40% of McDowell County's children are now in foster care, primarily because of this epidemic, because the parents are not considered competent to raise their children. Now think about that, 40% in foster care, and even the best foster care is not the same as being raised by your own family. So a lot of things converging that made this really compelling problem. But there are other consequences besides just the addiction. So I'll give you some data that we amassed in Cincinnati to back up the claim to Cincinnati officials that we needed a syringe exchange to stem the spread of viral hepatitis, HIV, and we also use the syringe exchange as a way to teach people how to prevent overdose and to distribute the overdose reversal drug, naloxone. So 2/3 of the people we surveyed, and this is back in 2009, reported finding dirty used needles primarily in public places. And almost 40% of them reused what they found. And half of that 40% just used what they found without doing anything. And the other half used inadequate methods. And I remember one gentleman said to us, well, I rinsed those needles with puddle water. Well, I don't know if there's probably not many microbiologists in the room besides Rita, but puddle water's got a lot of germs in it. This is like saying you pick up stuff from the street. And this is how people get this disease, endocarditis, because they are injecting bacteria right into their bloodstream. And this is just to give you a sense of how expensive this is to the healthcare system. Endocarditis, you need intravenous antibiotics for 6 to 8 weeks, okay? Here in West Virginia, where nursing homes won't accept these patients, they stay in Ruby Hospital for 6 weeks. Pretty expensive, because after about 2 weeks, they're not so sick anymore. So here is a 13-day hospitalization. You see, all of these individuals also had hepatitis C, and those 13 days, cost the system about $86,000. This doesn't include the doctor charges, because University Hospital is the county hospital, so uninsured people are covered by a tax levy. So this doesn't include anything for the docs. Docs don't benefit from the tax levy or the 5 or 6 weeks that people are going to spend in a nursing home. Here's a 20-day hospitalization. This gentleman needed an aortic valve replacement. So the bacteria ate a hole through his heart, and he had to go to cardiac surgery on an emergent basis. And his hospitalization for 20 days cost $174,000. And lastly, we have another gentleman who had an aortic valve replacement. He must have spent a lot of time in the surgical and medical ICUs, because his 17-day hospitalization cost $267,000. Now, I will tell you, we started a syringe exchange in Cincinnati for less than $100,000. So what you could abort in terms of medical costs, the cost-benefit ratio is just huge. And you find needles all over. So I'm sure if I took pictures went to the right places in West Virginia, I could give you pictures too. But these are pictures in Cincinnati. This is a playground 3 blocks from the UC Medical Center. On the right is the YWCA entrance downtown. I can tell you the names of streets in Cincinnati where it's just littered with needles. So the same activities give you viral hepatitis B and C and HIV. And I emphasized, of course, injection drug use, because that's a very good way to transmit infection. And many of you may have heard about this outbreak of HIV and hepatitis C in rural southeast Indiana that started in 2015. And in a town of less than 3,200 people, there are now 210 cases of HIV. And the vast majority of them, of course, also have hepatitis C. And this is what I'll tell you in a second. So in terms of needle sharing, the ability to give HIV to someone else is probably related to the inoculum size, how many viruses are in whatever fluid someone encounters. So of course, a blood transfusion gives you a 90% chance, because you're getting a pint of blood that has HIV in it. But if you are needle sharing and an injection drug user, That is the second highest way to get HIV because there's residual blood inside the needle and in the base of the syringe, and it is a riskier behavior than any form of sex. And here's what Scott County looks like. It's got the worst health status in Indiana, poor health care access, high unemployment, poverty, and people who haven't graduated from high school. So very similar to parts of West Virginia. So the CDC, based on the Scott County outbreak, the CDC did a study to identify the 220 rural, they wound up identifying 220 rural counties across America that were at high risk for HIV or hepatitis C outbreak based on the same characteristics I just described to you. And it's not rocket science, and you can see from the back of the room that central Appalachia is extremely hard hit. And West Virginia, it's like you couldn't even put the WVA in the same spot. It was so full of red. And here's what it looks like when you just hone in on West Virginia. Okay, there's 28 of our 55 counties are on this list. And the ones with the highest score are right down here in the southern coal fields. So I'm going to show you in quick order. This is what the acute hepatitis C case rate looks like. And you can just see it move. This is 2012, 2013, 2014, 2015. So you see the initial concentration is very high in the southern part of the state, but it is spreading north. And Preston County, right next to Mon County, where we are, is now got the dark blue, has the dark blue color. And why do we care about hepatitis C? Because this is the #1 reason for a liver transplant in this country. So this is an important disease and a bad disease. The vast majority of people who get hepatitis C, 80 to 85%, will go on to have chronic disease. A lucky 15% will clear the virus with no further sequelae. And then the people with chronic hepatitis go on to have, a significant proportion of them go on to have cirrhosis, and then a lot of these people die. And they die of cirrhosis, they die of liver cancer, they die waiting for a liver transplant. So now, just to give you a sense, in the insert, that's the last map I showed you, right? The 2015 hepatitis C rate, looking just at the bottom half of West Virginia. And now this is a heat map of the, I keep pressing the wrong thing here. And this is a heat map of the overdose death rate. And you can see that the overdose death rate is highest in the same counties where the hepatitis C rates are, because this is the worst part of the heroin problem. So this is data from Cincinnati, but I think it's probably generalizable. The first use of, in our sample there, the first use of prescription opioids happened at about 21 years of age. For the first time people graduated to street opioids was 4 years later at almost 25. And this was typically snorting heroin, smoking heroin. Then in less than half a year, right? People go from snorting and smoking to injecting. So a very fast transition. And 2 years later, on average, they experience their first overdose. So it's, a fairly rapid progression between, 21 and 27 and a half. This opioid epidemic is, of course, largely in young people. It does include some people in their 30s and 40s and even older than that, but it's primarily people under 30. And it includes teenagers, which I think is particularly frightening. The population level impact of these deaths from the opioid epidemic is striking. So these are data from a study that was published by a Nobel Prize-winning economist, Angus Deaton, last year. And this is, it says USW, it stands for US white population. So here it's like France, Germany, the UK, Canada. So you see the death rates are going down in all of these other high resource countries. But the death rate is going up in the United States, especially among middle-aged whites. And then you can see here's the causes of death, and this big red line here says poisoning. It's just that's just another technical word for overdose. And actually poisoning has outstripped lung cancer as a cause of death in this age group. The other things that are increasing, of course, are suicide and chronic liver disease. So all bound together, I think, with this terrible opioid problem. So the transmission of HIV and hepatitis B and C, aside from blood and sex, can also be transmitted from a pregnant mother to her newborn. And although the rates of transmission for these three diseases really varies, the outcomes for the kids are severe. And why do we care about this? Because almost half of the opioid addicted individuals now are young women of childbearing age, so 15 to 44. And these are a lot of women who are getting pregnant, just getting pregnant. And here is data from neighboring Kentucky that the CDC published last summer. And this shows you the increasing proportion of infants born to hepatitis C infected moms. Okay, so here's the US rate, a slight increase from 2011 to 2014, but in Kentucky, a dramatic, I mean, even in 2011, their baseline is high, and a dramatic increase. And I think if you looked in West Virginia, it would look just the same. So neonatal abstinence syndrome is this withdrawal that newborns experience. Again, this is a heat map. The darker the color, the worse off you are. So it's us and New Hampshire and Maine, but we actually have the highest rate. And this overall in the United States has increased 300%. So it shows you that not only West Virginia, but many states are suffering from this heroin problem. And we had the highest rate, 33.4 cases per 1,000 hospital births. 80% of these hospital costs are borne by Medicaid. Many of these babies have developmental, behavioral, and learning disabilities. So what's going to happen to these kids? What is going to happen to these kids, especially in places where 40% of them are in foster care? I really worry about that. I worry about whether they're going to be ready to go to school. I worry about how they're going to be managed in school if their behavior is obstreperous. So what can we do about this? I just want to take a minute to mention the public health principle of harm reduction. So this is a way to minimize the harm from certain behaviors. These are not behaviors we condone, right? Nobody wants to say that injecting opioids is a good idea. But until people are ready to go into recovery, the concept is you want to keep them alive and healthy so they can get there. You know, a dead person is not going to go to recovery, and recovery is going to be really difficult if you have AIDS and chronic hepatitis C. So the whole point is for this to be non-judgmental. You offer services to PWID as people who inject drugs, and you try to assist them in reducing the attendant harm, and the contact with the harm reduction community makes the people who are suffering from addiction feel comfortable, develop trust in you, and sooner or later they come in and say, help me. You know, I gotta get off this stuff. And at our Syringe exchange in Cincinnati, from the outset in 2014, a consistent 10% of the people we've served have gone into recovery. And I know that sounds like a small number, but actually that's really quite good. So because there's so many factors leading to these problems, there's really not going to be, obviously, a single way to resolve this. So one of the things we need to do is increase access to drug treatment programs. Currently, across the United States, only 10% of the people who need drug treatment are getting it, only 10%. And at WVU, our addiction treatment center has 450 patients and a waiting list of 600. So there is not enough treatment available. The other thing that's important to point out is that much of the access, much of even this 10% access to treatment has been driven by the changes of the Affordable Care Act, which said drug treatment would be paid for. Insurance before this didn't pay for that kind of thing. And drug treatment's expensive. So even if you wanted to be in recovery, you didn't have much of a chance. And people who tout abstinence is really only successful in a small handful of people. The people who can do that, well, God bless them, but the majority can't. And because their cravings, because that aberrant brain circuit is operating, their cravings are so strong. We need increased access to naloxone, which is the drug that reverses an overdose. People are blue, they're breathing 4 times a minute, they're really dead, close to dead. You inject them or you squirt it up their nose, they sit up, they look around, what happened? I mean, it's striking how fast that works. We need increased screening, treatment, and prevention for serious infections. We need syringe services programs. When I came to West Virginia a year ago, there were 3, Morgantown, Huntington, and Charleston. Now there's one in Wheeling and in Martinsburg. Really, every county in the state needs a syringe services program because people will get clean syringes. They should get clean equipment to prepare the drug because hepatitis C remains contagious on the injection equipment, whereas HIV really is only contagious in the blood. And they need condoms, and they need education about safer sex. They need to learn about overdose prevention. And you need to create that bond so that they will trust you and say, when they're ready to do it, you're there to help them. I think in Appalachia, maybe not in the entire United States, but in Appalachia, routine prenatal care should screen for opioid use and hepatitis C. These are not part of the routine workup for a pregnant woman. Hepatitis B is and HIV is, but not these other problems. And I think the obstetrician and then the treating pediatrician need to know these things. Because if you don't know that the mother got chronic hepatitis C, then you won't test the child. And it's critical to test the child because we have curative therapy for hepatitis C now. You take 1 pill once a day for 12 weeks, gone. So, rather than consigning a proportion, a number of children to chronic liver disease and the need for a liver transplant, you can fix it when they're still quite young. So I think that's a very important thing. And then we need primary prevention. This is the thing we've been the worst at, trying to convince people that they shouldn't even try these drugs. And I'm not a primary prevention person. I can't tell you that I know anything works, but sooner or later we got to find something that works. Naloxone, which reverses those overdoses, is increasingly available, but because it's in wide use now, the cost of it increases quarterly. To deal with the unplanned pregnancies and neonatal abstinence syndrome, we need to ensure that there's access to long-term implantable birth control, and then screen for opioid use, as I said. And we need a lot of research for how are we going to care for these babies many of whom are significantly damaged. We need research, of course, because how are we going to find our way out of this? We need all kinds of multidisciplinary research. And lastly, I want to really emphasize we need to reduce stigma. And I know this from 30-some years of working in HIV. Stigma keeps people from accessing care. If you think the doctors and nurses you're going to encounter are going to shame you and belittle you and be hostile to you, then why would you go see a doctor? And so really most people with the disease of addiction wind up going to emergency rooms for care only when it's absolutely necessary. And it doesn't solve the problem. To point fingers and say you're a bad person does not solve the problem of addiction because it's a disease. And we really need to start thinking about it as a disease and not a lack of willpower. About half of the vulnerability to addiction is genetic. So we really need a lot of research into genetics and epigenetics to figure out what could we do, what kind of preventive things could we tailor to the individuals who are really at risk. And I won't talk to you about the current studies I'm doing because I want to give you a chance to ask questions. And thank you very much for your attention.